Okay.
Great.
Hi, everyone, and welcome to PSW Podcast, Coffee and Conversation. I am Rita Romanovic. I'm the CEO of the Ontario PSW Association, and I'm joined by Ian De Silva, who is my Chief Operating Officer. And we have an issue right now because it's not going live on Facebook. But anyways, we're just going to continue moving forward here because we do have people that are watching currently in our actual webinar. So we're here today to talk about healthy aging in place. So Ian, why don't you take it away?
Thank you so much. Hello, I'm Ian De Silva. I'm CEO of Candace and we're here today with Jim Gloss and Candace Chartier. They're going to be discussing Carefall. Two excellent experts in this field. I don't think there's anyone we'd rather be speaking with when it comes to discussing the future of home care. So welcome to you both. I'd love you both to introduce yourselves and tell me a bit about what you're doing. Whoever would like to go first. Candace, ladies first.
Sure. Hi, everybody. Candace Chartier. I'm an RN by background. I've worked in the senior care space for many, many years. I was CEO of the Ontario Long-Term Care Association for 7 years and have done some work in the social model of care out west in BC, and have really been focusing in the last few years around upstream approaches to addressing care for the elderly and what we can do with innovation and technology. And I'll punt it over to Jim.
Hi, I'm Jim Close. Been the same amount of time as Candace in senior elderly care, accessible design, probably now going on 33, 34 years. Much of it in home care. A lot in LTC and senior care there, but a lot in home care. A lot of designing homes around the concept of aging in place way before we started calling it aging in place. There was just people getting discharged from hospital and trying to make ends meet. And if I even think back to my childhood where my grandfather had a stroke very early, I just remember being at my grandma's house with plywood ramps and kitchen chairs and bathrooms and visiting nurses every now and then, and visiting PSWs probably back then when they weren't called PSWs. Kind of maybe that was the fostering of my career and didn't really know about it until much later. So always involved with sort of after the fact, after the incident, after the discharge. And when Candace and I reconnected a couple of years ago, as she mentioned, thinking more upstream, thinking more about your topic of healthy aging in place and how can we get ahead of it before having to deal with it when it becomes a crisis. That's what we're all about. That's what we're trying to fix. Well, fix is a bad word, but trying to get to.
No, let's stick with the word fix because I think the word home care and I think crisis is a word that comes into a lot of people when they're actually dealing and navigating the existing system. So I think really what we're looking to discuss today as well is expanding on the upstream approach to what you're trying to do. And I'm going to speak for Miranda. We recently were at the Toronto Home Show, and a lot of the questions that we received and that we were referred to came around: when is the time to plan for home care? What is the options of home care? And especially, and nothing against long-term care, but we want long-term care to be a last option. And if maybe we can talk a little bit about Denmark and some of the things your work did there. So let's talk about the upstream, if that's okay. Miranda, is there anything that I missed or?
No, I think it's important that we talk about this, but also too, we're going to touch a bit later on in this about PSWs, because that also was a huge topic.
Yes.
I mean, at a Toronto Home Show, and we were one of the most popular booths that was there. So, interestingly enough, but I'm very curious to hear about Denmark because Ian's told me all about it.
Yeah, maybe I'll jump in and start. So we had the opportunity to participate with Durham College, and Jim can give you a little bit of background about how he actually was the one that orchestrated our involvement. But what Denmark's doing is they're really looking, what they've done in that country is absolutely incredible around putting the senior right at the center, and a really relationship, social model, emotional model of care. And we did a similar model, and I think it's the first in Canada that really reflects the Denmark model. So when I was out in BC with Providence Living, we built the first publicly funded long-term care home based on the concept of a dementia village. So we did the research, we did the Hogwick, we did all of the European research, but what we did was we took pieces of it and really built a model called Home for Us. And what it is I think the future of senior care going forward for care for older persons. And basically what it is it's putting that older person at the center and wrapping their social life around them and not changing it. So going from that institutional model where it's staff and resident, more so the residents at the core, and they continue their life and their wishes and their wants and their likes in a setting that adapts to them. I guess I'll stop there because I could go on for hours, but it is a totally different approach where more family involvement, more friend involvement, more volunteer involvement, and really we're in their living space. They're not in our living space.
We philosophize about that here in Canada and Ontario, that we're in their home, but it doesn't really necessarily translate all the time.
Exactly.
One of the things I remember about the presentation was specifically around, as very much it is about resident safety, but it was also a large element about worker safety and the differences in training. Jim, did you agree with that when we?
Yeah, I was gonna jump in there because it did make a couple points in relating it to the PSWs. First though, I would have to say, as it ties into what really resonated for what we're doing, is back in, like, I believe 1991, there was actually policy and legislation brought in about preventative health. So they actually have legislation put in place for all these things that they talk about. So you just kind of said quickly there, Ian, about, we philosophize about these changes, and we talk about it, and we have great webinars, but there's no real policies that are put in place to basically force people to undergo some of these changes. And so that preventative health element was PSWs, OTs, PTs visit regularly to do a preventative, whether they're ill or not, or there's been an incident or not, they do wellness checks. It's all that simple there. But to your point about how and the other thing about when it comes to the support workers, is there's no limit to the how many hours or how many come into the visits. It's all cross-bled into what responsibility. And what stuck out is Katie Tucker from the Danish Consulate said they can have as many as 10 hours a day of PSW visits, basically, and it's all paid for. And I like the concept of what they came up with when they talked about technology coming into play. Well, let technology do the paperwork, let technology do the routine scheduling, et cetera, but have warm hands approach to care, meaning that your membership as a PSW goes in the home and focuses on dealing face to face with the client, dealing with the care. Technology is behind the scenes. It helps a lot, but it frees up time to have that they called it warm hands approach, and I thought that was pretty telling, I think.
And there are levels of care. You have your private residence, and then you move into like a sort of retirement facility and
supportive homes. Yeah. And they're building communities. They don't build. I think that was another legislation that they did in the early 2000s, where they basically outlawed warehouse type buildings of long-term care, and they built smaller buildings that wrapped around with smaller condo type living, townhome living, where the support is there close by. But as people transition, the transition is quickly done if they need more care. And I believe they said something like the waiting list times are 23 days versus Candace, I don't know what even the waiting times are. I know the waiting list is huge, but I don't know what the times are, like a year, 2 years now, some cases.
Depends. Some homes are upwards of 3 to 5 years. Like, it's crazy. Depends on the home, the location. Yeah.
So the whole concept there, and again, Ian, is just to try to extend the person living in their own home, their own environment, as Candace pointed out, surrounded with their own environment, surrounded with their own social structure, because that's where they want to be. And post-COVID here, everybody did a survey about asking Canadians where they want to live, And it started at about 80%. And I think if you asked anybody now, any survey is about 100%. Nobody wants to move into long-term care. They want to age in place. So is anybody listening, I guess, is the other thing. I read a quick article this morning on LinkedIn, I believe, and I was going to bring it up on Tuesday, but didn't want to get too political about it. But there hasn't been much talk in this election, and I know there's other huge issues at stake within the election, but there hasn't been much talk about healthcare reform, elder care, or anything of what I said. So some of these things I said about policies being drafted in Denmark 30 years ago, they're not even on the agenda right now here in Canada. So it's interesting.
Not at all. And speaking of like, so Miranda, you've actually done home care. Can you tell us what's home care like? And we know what our members say. Let's jump in there and talk about
You know what our members say?
about this right now.
Okay, sure. I mean, so for people that are watching and don't know, I am a personal support worker, and I worked as a PSW for many, many years on the front line here in Ontario. And a lot of that time was in home care. And home care was, I worked for a public company, I worked for a private company, and I also worked for myself as a PSW. And it's interesting because a public company, I got lots of shifts, I got lots of different clients. There was really no continuity of care, which was unfortunate because you can become, I don't want to say the word is attached, but you become invested in the clients that you care for, as any human being would be, especially when you're doing the most personal care, literally, on an individual, and you're responsible for it. So I mean, that was interesting. The private system, again, well-meaning, a lot of people start these companies or start up a franchise because they want to make a difference, because they want to, be able to give that care to people in their homes. And then of course there's PSWs that are working privately. And one of the things that we noticed with a lot of our PSWs was the rate of pay. So not to get too political in the rate of pay here, but a lot of PSWs talk about if they work for a public agency, they're making a lot of money. If they work for a private company, they're unfortunately not making a lot of money, depending upon where they work. And if they work for themselves, they're actually making a good chunk of money. So then we ask, what is the future of home care? What is the future of home care in Canada? I like how Denmark does it. My family is from the Netherlands, and we like how they do it in the Netherlands. They seem to be more invested in their senior and elder populations, as opposed to us in Canada, which I hate to say. And so how do we enact that change? How do we make that difference? PSWs want to make a difference, but if they're getting 60 hours one week, and then suddenly all these clients either go into long-term care homes or assisted living facilities or retirement homes because the care hours are just not there, then they're down to 2 hours the following week. So how do we maintain the PSWs in the home care sector, and how do we make it operate? I'd love to hear what both of you guys would have to say. Any ideas on that front of how you make it a success?
So we're doing, I'm actually supporting an organization right now doing an end-to-end bundled solution. And it's actually quite incredible what we're doing. And this organization was typically in the acute care space. So it wasn't in long-term care during COVID or anything like that. And we're working with, we've been working with an acute care organization. And what we've done is we've created a short-term transitional program where, targeting hospital to home. So getting people out of that hospital and getting them home as soon as you possibly can, before they decline any further. And basically, we started this at the end of January. I'm going to say we're upwards of 80 or 90 transitions so far, but this is short term, just, immediate transition. Our PSWs go in, our registered staff goes in, does a quick, not quick, but does a head to toe complete assessment. And then what we do is we determine what are their needs based on the next 72 hours. And so it's very, very short term, and that period of moment of time before Ontario Health at Home takes over. So, but also being very fiscally accountable in the sense that you don't want to put like all these services in and throw the kitchen sink at them, where all of a sudden they're going to go to the public system and have decreased hours of care and not be able to cope. So we're taking a very upstream approach where the PSW goes in, If they qualify, we do an assessment, which you'll see behind Jim, called the CareFall. And what it is it's a cognitive brain mapping, hearing, visual, gait analysis to see what their risk of cognitive decline and falls risk is. And then we work with the families and we say, okay, here's some really cool brain and strengthening exercises you can do with your loved one, that when the next PSW comes in from whatever organization has the contract, here's a list of exercises that they can do with your loved one. And we're pretty excited because we're getting a lot of successes from it. The PSWs really like it because what we've done is we've customized it so that PSW, where possible, stays with that client. And I think that is huge because that's the relationship model right there. And we've got families calling us and leaving messages, and like they're just one lady was in tears. She's like, I just love what you've done. I never thought I would ever see my dad back home. So the art of the possible is there. It's just we have to do things a little differently and taking this customized approach where you try to match that PSW with that client, with that family member, and bring that family into that circle as much as you can, or even friends or volunteers, and how innovation and technology can support that. It's going very well. We're in our 3rd month.
That's awesome.
Congratulations. That's amazing.
Yeah.
If you can share anything more about it, we're welcome to hear about it. It doesn't sound like it should be a secret or anything.
Here's my question. Can a PSW refer? So like if a PSW is familiar with CareFall and then they're working with a client and they're working with their family, could the PSW refer the family to you guys?
Absolutely. Yeah. And I mean, this organization, when I first met them, I was like kind of blown away around their different approach to wanting to be that end-to-end solution. Because I know personally when my dad got sick and I had to leave, I was out west and I had to come home on the red eye, and what I came into was a nightmare, and I couldn't find care for my dad. And I'd been in healthcare for 30 years and trying to get him the resources that he needed. And one of the things that I mean, our local hospital was incredible. I couldn't have done this without them. And, at his discharge after his 2 weeks in the hospital, it was all of these services all coming into his house and everything. And I was like, this is great. But now that I reflect back, I'm like, wow, if we'd have done the CareFall assessment, we could have, of course, it's a plug for us, but we could have identified what does he specifically need and go from there. But PSWs, I reached out to Facebook to my friends and family and said, I need a PSW to go help me with my dad. And I mean, the fact that I had to go on Facebook to find one, there's an issue. So
we do the same thing at the OPSWA.
Yeah, but until I lived through that, I mean, you guys know my background.
Yes, it's
I mean,
Same.
jumpings, I never thought I would have to go through something like I did with my dad, and it opened my eyes and my heart to how things have to change.
kudos.
Oh, and I love that because I mean we had a similar situation with an actual former minister of the Ontario government who reached out to us because they couldn't find a PSW. So you think about that too, right? With your background and former minister in the government, it mind-blowing how they can't find PSWs. So
well, I mean, it's a lot.
Go ahead.
And I think if I can just jump in, I think it's, and I think we talked about this, is that it's how disconnected our delivery system is from the actual patient. And I think that came across at the thing we did on with Durham College, that Denmark trip. We are disconnected. We can't find we're the PSW Association. We struggle to connect people to PSWs in an emergency. And in the actual deliverers, these mysteries. So there's a lot of questions. So I guess on one hand, I'm glad that at least it doesn't discriminate. On one hand, the system, it doesn't favor anybody. So there's at least something there. Do we have any? Sorry, Miranda, you were going to bring up something. Sorry.
I was just going to say too, just to play into what Jim and Candace were saying in regards to the wild wild west, shall we say, that is home care across our wonderful continent. Is the interesting part about the Toronto Home Show that we found was no one knew what a PSW was.
Oh, wow.
And which was really interesting. The ones that did know what a PSW was were trying to find PSWs, like we were just talking about, and couldn't find PSWs, or they didn't know where to go to find PSWs. And it became such a, because this was our second year with that particular vendor there, and we actually made up postcards that had QR links to Ontario Health, Ontario Long-Term Care Association, Retirement Home Retirement, Regulatory Authority, because people don't know these things. And it's interesting because us who have all worked in healthcare, I'm in my 20th year working in healthcare myself, and we all think, well, you just go here, you just go there, this is what you do. But for the average person who's just living their lives, doing a 9-to-5 job or doing whatever they're doing, and they're not working in healthcare, they literally have no idea where to find the supports and what type of supports they should need. It's amazing how many people would say, well, I'll just get a nurse.
Oh, and 10 years ago, I was sitting in Tim Hortons, and there was a group of older ladies beside me, and they were talking about how healthcare was, or long-term care was free. And I was like looking at them and I was like, wow. And I remember racing back to my office at the Ontario Long-Term Care Association and saying to my team, we need to educate people on this is long-term care. This is what it's about, layman's terms. And that's where it evolved. The This is Long-Term Care report, aimed at our legislature as well, for our MPPs and our MPs, but the general public. This is what long-term care is. Here's what you need to know about it. And then that's where we created the This is Long-Term Care conference, with a focus on innovation, quality, research, to really bring out what the best of long-term care was. That was 10 years ago. And it's unbelievable how people just don't know. And that's where the associations are key. That's where you guys are key. CANSWA's key, OLTCA, ORCA, you name it. That's where it's got to be that push out to the general public. Like, this is what the facts are. And in layman's terms, here's what the scenario looks like.
Well said.
So that's like our goal, right? With doing these PSW podcasts, coffee and conversation. I already know you guys will be back at some point to talk more about what you guys are doing.
I want to ask, can I just jump in?
Yeah, go ahead, Ian.
Jim, just to talk about a bit more about the planning and things. Jim, can you tell us, there's a couple questions coming through our chat as well on the Facebook stream. So Candace, there's some questions about the organization. People want to know more about it. So we're going to ask about that in a minute. But Jim, tell us, you were going to bring in a comment. I wanted to make sure we
I was just going to say, it's interesting what Miranda said about people not knowing about what PSWs are. So as I said earlier, my entire career was basically around changing the environment for safety, because what happens is, mom or dad fall, that's a big thing. We as a vendor would get the call, so we would be the leading edge in a lot of cases. Like, I'm going to say 80% of the cases, the vendor was the leading point of contact. Yeah, that's how I reconnected with Candace, because her dad called me, or her father-in-law, and so it became, a good vendor would start to know to point things and point them in directions. That's what a good vendor would do. But again, the term even home care nurse or PSW for sure never really entered the conversation until the renovation was done, or the installation was done, or the wheelchair was delivered. The OTs, and I worked with OTs my entire career, and fantastic profession, but they're almost one-off, right? Because they're stretched too. They get an hour to do an assessment on the person for their wheelchair, for the environment, which is the other reason why I started Age Safe, which is a safety kind of course for everybody to do the environment check. But the terminology of PSW came miles after the fact, and more to Miranda's point, vendor, original OT kind of leave, and there's still people asking those questions. Candace illustrated it perfectly. Like, who's next? Yeah. You can't leave mom and dad there to ride their stair lift up and down and think they're fine for the rest of their lives. That what's happening. What happens now? So that was more the point I was going to make on that, Ian. I believe.
No, thank you. I think that ties into, when do we decide as adults to start planning for home care. I mean, if this is what people want, home care, and we've all discussed this, it seems like it's always happened at the very last minute when they're like, okay, I'm at home, I'm injured, now I need home care. What am I going to do? I mean, it's
That's exactly it.
plan for injury. So I
That's
think that
exactly
whole
it.
thing,
Yeah.
the planning for falls is brilliant. It would be,
Well, I used the marketing term years ago when I sold stair lifts primarily as a living. Is like nobody saves up. You don't have a registered
oh,
stair lift savings program to say I can't wait one day to tap into that and buy my first stair lift. Like
no,
nobody's waiting. Nobody wants to do that. I can't wait to have my first PSW. I write them a check so they can wash me. That's nobody's planning for that.
you're
But
right.
you have to, right?
You have to. You have
It's very unsexy to save for that or to plan for that. But one of the things that we're doing with Carefall, even though we're doing primarily what Candace illustrated, is doing assessments for people who have already gone through the hospital
yeah.
scenario or going into long-term care or are in long-term care. We'd like to see this assessment done for more active seniors in the community as part of what we said earlier about Denmark is the preventative side of things. If people in their early 70s or late 60s start having a full screen, so we're again Carefall, different than other screening processes in that it's biomarkers using technology that are objectively based, so nobody can cheat the system. You know, a lot of falls prevention surveys, people can cheat the system and just lie on a form, and nobody ever takes it any further. We capture the data, and it's there forever. It's like your blood pressure. It's like your, it's screening for a cancer. So,
Gives you
obviously our
information
end,
you didn't have, which is the key thing.
it's there, and it's there forever, and you follow the person's progress. And from a ROI, Ian and I talked about this a little bit, is eventually, very soon, we can go to the government and say we've reduced falls 25, 30, 50% in certain environments. That's saving billions of dollars. Where does that billions of dollars go? Let's reinvest it back into the things that we're talking about all throughout this whole conversation. Let's start paying a good wage to PSWs. Let's start, hiring more and training more so that those 10 hours a day, if needed, are there available to the public.
I agree. And like Denmark and like Sweden and like Norway and all the other Scandinavian countries in Europe, the backbone of that system, in our opinion, this is going to sound biased, is that they use regulated, title protected individuals to perform that care, which is where our members have a lot of issue because we have people that have no healthcare training coming into home to provide care because anyone can do this job, which is another element of education that we deal with, Candace, from a public point of view as well. So we get it. But it's one of those constant education things. And I think that this is the beginning of this conversation for us.
Oh, yeah.
And there's so much more to go through. And Candace,
Can I just say something though really quick?
Yeah,
I just want to commend you guys for doing this program. And the reason why is because you were talking, Jim, about research. And that's what we see a lot in Canada, unfortunately, is oodles of money being poured into these, and I mean, guilty of sitting on them myself, as the association, and Candace, you as I'm sure, and they do so much research and over the years on PSWs, on fall prevention, on Alzheimer's, on dementia, on all this different stuff. And what happens is no one moves past that research. And so I love hearing that you guys are like, in the next while, you guys could come forward and say, we reduce these falls by 30%, by 55%. I'm hoping 100% for your guys' sake. But I commend you on actually doing something as opposed to just sitting back and saying, this is a really good idea.
Well, I think we want to embrace the philosophy, that philosophy, Jim, you gave a couple days ago. How you define what Canada is the land of.
Mm-hmm. Yeah, we're and I'm not. I have that was unsolicited, Miranda, but thank you for the lead in, because we've said it often, and really the reason Candace and I came together, there was research companies, there was these small OEMs with technology that were getting frustrated that they couldn't move forward. So we do have a lot of technology, and the technology that we brought in are ready for market. It's ready to go. It's just we can't get beyond this research, and even now, when we say what we do, we have government kind of scratching their head going, I don't quite get what you're doing. Where's your research? The research is already there. It's already there. We're the land of pilots. And
exactly.
And
yeah.
A lot of people have said it. We're the land of pilots, and we research the hell out of things. And we pat ourselves on the back and saying, what a fantastic, look at the results of this pilot. That pilot might be 100 people, it might be 200 people. Even if it was 1,000 people, it sits dormant and they move on to the next pilot project.
Exactly.
Well,
That seems
we
to be.
want to implement it, and you know, there's no real risk. There is no risk in this. It's risk averse. Even if there was something, we're not doing anything that's riskful. In fact, if we don't move forward, we're never going to move forward. That's pretty deep, but that's,
No, but
that's
it's
the
No, you're
reality.
right. You're
truth.
right. You're
It's the
completely right.
truth. I mean, that's what I'm saying is, at the association, we've done the same thing where we've just moved forward on certain things instead of waiting for permission. Ian likes to say we ask for forgiveness half the time if we have to, because we just move forward and we kind of think outside of the box. And this is kind of that same kind of idea where you're like, but it's common sense. You think it's common sense. But unfortunately, our democracy has worked the way it's been working for the last how many years, and hopefully
But we'll
we
work
can
to
move
change
forward with
it.
a bunch of stuff. Hopefully.
Candace, do you have any thoughts, or did you want to?
Yeah.
Well, I just think, and I've said this before, the best thing that came out of COVID is that our risk adversity for new innovation and technologies plummeted, which is great.
Yes.
And, a lot of really cool things came out of COVID because we needed it and we needed it now. And I think it's a lot of what did come out of COVID on the innovation and technology side saved a ton of lives, right down to vaccines. So, I mean, if anything, if we've learned anything, it's like, okay, let's keep moving that forward. Let's keep pushing the envelope on what the art of the possible is. And I say it 1,000 times, work smarter, not harder. It's especially your PSWs. And I've always felt this, even when I was with one of the organizations that I worked for 17 years. The PSWs are the eyes and ears of our healthcare workforce. They're the ones that are out there. They're seeing things first. They're hearing things first. And the more we equip them with the toolkit to be able to enhance that quality of life, whatever setting they're in, they're our first line of defense. And if we can layer in technology and innovation that allows them to work to their full scope to enhance not only their work life, but their lives that they're touching every day. That's the mandate that I want to see. That's where, we love it. Like we've launched Carefall in an organization. We're in 3 of their homes, and honestly, the programming and the busyness of the homes with the PSWs and the atmosphere, I missed it so much. And I'm in those homes and I love it because I can see that side of it. And I mean, long-term care is an amazing space. It gets a lot of flack, but it's an amazing space. And I think it's only going to get better going forward. But we need to equip our PSWs with the toolkits to make that happen.
Make them into a little leader and have them out in the community, and we'll have a much stronger system, I think.
Exactly.
Absolutely. I
Candace-
would have killed, by the way, Ian, I would have killed for this Carefall when I worked in long-term care. So we're not saying, PSWs that it's only home care, because I think it's great that you guys are in 3 facilities and that this is really going to help the PSWs, because I can remember having those residents that, Jack would have a bell on him, but or he'd have a device that would go off, but he'd figure out a way to get that off of him and he'd get out of that bed regardless. And the next thing you know, you got Jack making his way down the hall on his hands and knees because he had fallen. And yet, you know what I mean? So I'm sorry, I'm raving about you guys, but I really think it's a great thing.
Candace, there's been some questions on Facebook about the association that you were speaking with, that model between hospital. Are you able to share that, or did you want us to share it after?
Sorry, about the what?
The association. People are asking about the one that you were speaking about that helps people navigate prior to going to hospital. Or when
the hospital to home piece?
Yeah, are you comfortable sharing that or making it available to our members after?
Oh no, it's literally a hospital. So each hospital across the province, I believe, has a hospital to home programs that they're building. So I think they're similar, but I think they're all a little bit different. So I think it's a matter of the organization that I'm working for.
Yeah, you were mentioning that you did an organization. Sorry.
Yeah, so it's Helping Hands Healthcare. So they've actually got they've got a whole end-to-end program where regardless if it's long-term care, retirement, acute care, really targeting a very customized approach to getting people from acute care back into their own home in that transitional phase.
Okay, so
So they've actually adopted Carefall. There's another really cool innovation around skin and wound called skinopathy. So they've bundled these innovations and these technologies into their customized program.
I like it. Okay, no,
Yeah.
there's a lot of questions and curiosity about it, positive curiosity. So
Yeah, no, it's pretty cool. It's they're a pretty innovative group, and I loved working with them.
that's great to hear. Thank you so much. I just want to say, Mandy, do you want to finish off?
I think we've done really well. This has been so informative. I hope that everyone that is watching, if you guys have any questions, if you guys want to know more about Candace and Jim and what they're doing, reach out to us and we will connect you guys with Candace and Jim. Absolutely. I'm sure Carly, our marketing director, or Nicole will be putting links below for you guys to find out information and so on and so forth. And with that, I'm just going to say thank you so much, Jim and Candace. It's a pleasure seeing you guys. And I'm sure we'll have you guys back again, as I'm sure there'll be a lot of questions from this webinar. And with that, Ian, thanks again.
Thank you. No, thank you both for coming. It's great seeing you both again, and thanks for everything.
No, it was great.
Thanks, everyone.
Thanks
Take
very
care.
much.
Thanks,
Thank
guys.
you.
You
All
too.
right. Bye-bye.
Bye-bye.